Well, welcome to today's panel discussion related to the Massachusetts initiative to improve infection control in long-term care facilities. This session will walk through and outline the state of Massachusetts initiative to improve infection control in nursing homes. In response to the COVID-19 crisis, the governor of Massachusetts made additional funding available for 2 months to nursing homes to improve their infection control processes by supporting staff, personal protective equipment, and testing. So our session will walk all of you through an overview of the state's response, including the 28-point infection control competency checklist and the provision of additional support services to the homes themselves, as well as discussion on the collaboration with key stakeholders, including regulatory entities, which was paramount to the success of the outcomes of this overall initiative. We do have a few objectives, as you see here on the slide here, and we'll be walking through again the overview of this process, what this process incurred, and this initiative and the impact to the overall state of Massachusetts. We'll also talk about some of the involvement of the specific roles and the evaluation of adherence to the infection control competency checklist and the protocols that were set forth, as well as we'll discuss a little bit about the challenges that were identified, as well as some great best practices and lessons learned and the successful outcomes of this initiative. My name is Lisa Thompson, and I'm the Chief Strategy Officer at Pathway Health. Together today, joining me with our discussion are my esteemed colleagues. I have Helen Magliosi. She's the Director of Regulatory Affairs for Mass Senior Care Association, as well as my peer, Susan LaGrange, who's the Director of Education for Pathway Health and also oversees our infection prevention and control and our COVID task force for the United States, as well as working and was the project lead for this initiative and this program. So again, I want to spend a little bit of time talking to you a little bit about the background. And we know that this pandemic has really had an extreme hardship for healthcare, especially for long-term care facilities. This innovative program that we're going to talk about today was initiated by the Commonwealth of Massachusetts with the development of their Massachusetts nursing facility infection control competency checklists, routine audits, also had provision of support and technical assistance to identified providers, and it was unprecedented in this country. The program assisted providers in identifying areas of opportunity for improvement, gained further insight and knowledge of best practice approaches, and it impacted the overall reduction of community transmission of COVID-19 while assisting providers to mitigate the risk of COVID-19 spread for both residents and staff in their facilities. So throughout the short time frame of this project, significant improvement was identified and quantified. The coordinated effort between the state, regulatory, financial divisions, as well as provider association leaders, academic settings, and facility leaders is not common in many states. So I am very excited to, again, introduce Helen, who is part of our esteemed colleagues and our panelists today, and she was one of the key leaders in this overall initiative. So Helen, can you provide some historical or background information as to the why and how of this innovative approach and program?
Absolutely. Thank you, everyone, and good afternoon. So in early 2020, Massachusetts' 383 nursing homes, became a national hotspot for the COVID-19 infections with over 10,000 confirmed cases. The virus hit our most vulnerable populations in our nursing homes hard and fast. More than half of the state's deaths from COVID-19 occurred among residents in nursing homes. And on April 15th, Governor Charlie Baker made a $130 million additional funding investment available to nursing homes to improve their infection control processes by supporting staff, personal protective equipment, and testing. Next slide, Lisa. As part of that accountability and support funding, all nursing homes were audited, and supplemental funding was really contingent upon compliance with a mandatory testing of all residents and staff and adherence to a 28-point infection control checklist and its competencies. So the Massachusetts Senior Care Association and Hebrew Senior Life were asked to lead the effort and developed an infrastructure and processes to address this crisis. And this ask came from the state command center that was overseeing the COVID-19 outbreak and response in the state of Massachusetts.
So, Helen, can you tell us, once you had the combined team together, including Massachusetts Senior Care Association and Hebrew Senior Life, could you walk us through how you really developed that infrastructure as well as some of those processes that were there in order to address this crisis as well as implement this initiative across the state?
Sure. So we developed what we call the COVID-19 Command Center. And these discussions were actually in place prior to the state command center asking us to prepare a response to assist with nursing homes with the COVID-19 outbreak. So we prioritized and we developed sort of a strong support structure for our nursing homes. We identified 5 areas that our nursing homes were really struggling with. And they included infection control, PPE, staffing, testing, and data. So within the COVID-19 Command Center, we actually had these sub-command centers which were staffed, and focus was completely on the task at hand. And I'll talk a little bit about all of these, and I will talk about the infection control last. So for PPE, we were lucky enough to be engaged with MIT in Boston, and we staffed the PPE Command Center with nursing home leaders, staff from Mass Senior Care, as well as staff and students from MIT. And that group was really effective in developing a burn rate calculator for our providers so they could predict what they were going to need for PPE. And they also were able to secure PPE from China, believe it or not. It took a lot, but we were able to get PPE from China sent to us. There were delays, but it was much needed PPE once it arrived. Staffing, we again coordinated with Hebrew Senior Life, staff from MIT, and the staffing subgroup really looked at how to develop a position called a resident care assistant position. And with the help of the people from MIT, we were able to collaborate with Monster.com, and Monster.com actually advertised for staffing positions for every nursing home in Massachusetts. As far as testing, we also, once again, we collaborated with the Broad Institute, which is out of MIT, and this group took a lot of time and a lot of effort in sort of developing what a testing program should look like for nursing homes. It was clear from the get-go that we did not have enough testing available for residents and staff, and it was also clear that there needed to be some sort of a surveillance testing program set up. So Mass Senior Care with the Broad Institute actually piloted a surveillance testing program in 7 facilities, which was extremely successful. As far as data, we again had staff from Mass Senior Care and also MIT, and we were looking at data on a daily basis. We were looking at the rate of infection. We were looking at outbreaks. We were looking at deaths. And then further down the pike, as we started to work on the infection control and the infection control audits were implemented, we began to look at the data related to infection control and where people were having issues related to that process. Next slide, Lisa. So the infection control command center is where Lisa and Sue and myself and many others participated in. It was brought together by Mass Senior Care, again, Hebrew Senior Life, and nursing home leaders. We had medical directors who participated on this. We met daily initially to begin to work on how we were going to support these nursing homes in infection control. And my favorite saying, and I use it often still, is that we were really building the airplane in the air. We knew we had to provide support. We knew we had to get it there quickly, and how are we going to do it? So we developed a plan on how to provide support to the nursing homes on infection control, and one that we know now was extremely successful. Next slide, Lisa. So I talked a little bit about an infection control competency checklist. So additional funding was contingent upon compliance with a 28-point infection control checklist. And the checklist was designed to identify areas of deficient practice and to promote practice improvement. The checklist addressed 5 key areas. So it addressed infection, PPE, staffing, clinical care, and communication. The organization of the checklist and the detailed nature of the checklist was extremely helpful. It quickly let facilities, auditors, and our technical assistant team know what was already working well and where assistance was needed, and it allowed us to track improvement over time. There were 6 core competencies within this infection control competency checklist, and they were cohorting, congregate spaces, wearing PPE, donning and doffing PPE, infection control policies, and symptom training. And these were must-have. So what that means is that the facilities had to pass or be in adherence with all of the 6 core competencies that were in the infection control checklist. Facilities were eligible for up to a 50% payment increase on an average monthly basis from Mass Health. And over the course of the 8-week initiative, there were 4 audits and 4 pay periods, depending on the audit score. So the scoring rubric is on the right, as you can see. So facilities needed to score higher than 24 out of 28 on the checklist and be in adherence with all 6 core competencies to receive additional funding. If they were less than 24 or non-adherent, they would be reinspected in 2 weeks. The infection control audits themselves were conducted by state survey agency surveyors, as well as other auditors that were familiar with nursing home care. And they were all trained on the infection control competency checklist by the state. And I want to give a few examples of the checklist items because it will help paint a picture of what improving infection control in nursing homes during the pandemic actually entailed. So practices that were addressed in the infection control bucket included things like screening, cohorting positive, recovered, unknown residents, grouping them in separate areas, and hand hygiene. Areas that were in the PPE bucket included having an adequate supply of PPE, and the core competency looked for a 2-week supply. And if the facility didn't have that 2-week supply, there needed to be evidence that they were working on obtaining additional PPE. Every staff member in the nursing home had to have exemplary knowledge and practices related to PPE. And that included the actual right pieces of PPE for the right residents in the right areas, put on and removed the right way. Staffing shortages emerged early on with so many of our staff out sick, and facilities were expected to develop and be able to discuss a plan for how they would access staffing support through available resources, including the National Guard or a state long-term care staffing portal. And what I will say about the state long-term care staffing portal is it was developed by the state, and they actually provided a $1,000 sign-on bonus for anybody who applied and worked in a long-term care facility during this time. The $1,000 bonuses were also offered for facilities hiring staff through other means. In terms of clinical care, they needed to be able to recognize and report COVID signs and symptoms reliably. And finally, facilities needed to demonstrate a plan for how they would communicate with families regarding individual and facility-level COVID-19 updates. So this provides a brief snapshot, but it does describe the heart of some of the work that was done during that time period. Next one. So in April, this memorandum was sent to all nursing homes, and it came from our Mass Health Division and our Executive Office of Health and Human Services. And what this bulletin described was the infection control competency checklist and the expectations of the nursing facilities. It included adherence, how to adhere to the methodology, as well as the core competencies that all facilities needed to adhere to for supplemental funding. And this was just one bulletin that came out when all of this was being put into place by the state. Additional bulletins came out about additional funding for isolation space and criteria that facilities needed to meet to receive additional funding, as well as funding for baseline resident and staff testing. Next slide, Lisa. So who are the key stakeholders? So as you see, the nursing facility was certainly the center, the center of the circle, because we needed to know how and to provide the support that they needed. The Executive Office of Health and Human Services and DPH provided guidance, developed the infection control checklist, and responded and clarified questions. In addition, each nursing home was supported by a Department of Public Health epidemiologist and a Department of Public Health surveyor who made, constant check-ins with the facilities. They did this on a regular basis and were there to support the facilities. It was a much different model than our nursing homes were used to. It was not coming in to do a survey and citing deficiencies. It was to provide support to the facilities as they were working through this crisis. We also had a SWAT team. So the state had developed a SWAT team, which consisted of staffing members. So if a facility was in trouble with staffing, then the state would send in a SWAT team of up to 10 people, and that SWAT team would help staff the building until they could get through their staffing crisis, or they could secure additional staffing through temp agencies or hiring on staff. The command center is where Mass Senior Care and Hebrew Senior Life came together with those areas that I discussed earlier. And then we brought in infection control consultants and our own SWAT team. And our infection control consultants was Pathway Health. Next slide, Lisa. And this is just another way of showing how we collaborated and how we coordinated through the crisis. And when I say through the crisis, we started in May, and we had two very intense months, May and June, that we provided this support and worked hard to provide what our facilities needed to get through this. Next slide. So then when we developed our plan, we had to determine which facilities were going to need this additional assistance. And quite honestly, the state identified these facilities for us. Initially, there were 80 facilities that were identified at the beginning of May, and that was based on information that they had to send to our Executive Office of Health and Human Services. So we identified 80 facilities for the first round, and those facilities included facilities that had one or more surveys in the past 2 years with a citation at F880. With the information they were to submit, they were required to submit an infection control self-assessment. So those facilities that did not submit that infection control self-assessment or failed that self-assessment were put in this initial group. And then also included was the percent of clinical absenteeism. So any facility that was over 50%, was reporting over 50% clinical absenteeism, was included in that initial 80. The remaining facilities were identified by the first round of infection control audit. So anybody that scored under 24 points on their initial infection control audit were added to this group that were to receive the additional technical support. So in the end, we came out with, or worked with, about 123 facilities and provided that additional infection control support. They were our focus for this. And then there were 237 other facilities that we did watch and monitor based on their infection control audits. And if the state identified a facility that they felt needed additional technical assistance above the 123, they would reach out to us and let us know that we needed to add them to our group to work with. Next slide, Lisa. So how we identified our additional need? Well, we did identify quite quickly that we needed somebody, and we needed to engage consultants and people who were specialists in infection control. Because what we needed to provide individual technical assistance, consulting, and training with regard to infection control procedures to the nursing facility. Initially, they were in-person, boots on the ground visits. So all 123 facilities got an initial boots on the ground, in-person visit during a COVID crisis. After that, we identified facilities, and facilities were followed up with on a weekly basis to review the infection control competency checklist. There was support and implementation of best practices related to infection control, PPE, and clinical care. There was telephonic consultation to supplement in-person visits. And again, all of this work was with the nursing facility lead, and it was guided by the nursing facility infection control competency checklist. Technical assistance included, but wasn't limited to, review of infection control policies and procedures, identification and targeting of specific educational needs related to infection control, the provision of on-site training and education, hands-on review and monitoring of education through observation of the staff's ability to correctly don and doff PPE, follow established protocols, and perform correct hand washing. Train the trainers for ongoing observation and training of PPE for all frontline staff. The consultative visits, in order for us to facilitate the additional support and resources from our command center, we looked for what were the characteristics of people that we needed to bring in to be infection control consultants. And what we determined was that we needed people that had strong communication and interpersonal skills, the ability to find creative solutions to challenging problems, to have the ability to form collaborative, supportive, and non-judgmental relationships. They needed to have experience in long-term care and experience in training and education. Next slide, Lisa. So as I discussed previously, we had identified that specific criteria for the type of consultants that we needed. So when we reached out to Pathway Health, we reached out to them because we knew they had the infection control expertise. We knew they had the ability to scale to the size of need. And this project started out small and grew enormously in a very short period of time. We needed a quick response, and I know that Sue or Lisa is going to talk about that response. It was a 48-hour response, so we were able to provide assistance within 48 hours, and we needed it to be completed in 7 weeks. And Pathway Health were the ones that filled that bill for us.
Thank you, Helen, and thank you again for the overview of really this very innovative program and initiative that was conducted across the state of Massachusetts. And as Helen indicated, Mass Senior Care, as well as Hebrew Senior Life, reached out to Pathway Health from the command center, and they contracted with Pathway Health for our expertise, again, in infection control, as well as our ability to quickly scale to the needs of this time-sensitive project. And again, as Helen indicated, it was a 7-week duration. And between the time that we received the call, we were able to deploy a team very quickly and provide that assistance within 48 hours and quickly schedule and do those on-site assessments, which you're going to hear a little bit more about what that process was and how we were able to do that quickly, efficiently, and really target the needs of the support and education to the providers, as well as coordinate and communicate with Command Central as well. Just a little bit about Pathway Health. Pathway Health was founded in 1997, is a proven leader in providing services and education related to really industry, clinical, infection prevention and control, regulatory and quality improvement. And Pathway employs leading clinical and operational expertise really that to assist providers across the United States. So again, we had the expertise as well as the depth of resources to be able to quickly respond and be able to align with this initiative as well. So in response to that request for external infection control consultation, Pathway Health developed a scope in collaboration with Mass Senior Care and Hebrew Senior Life and Command Center, which included really 3 key components. And that was, as Helen talked about, those initial on-site assessments, as well as the provision of services and support to providers to those targeted facilities related to consultation and training, whether it was on-site, or you're going to hear a little bit about our innovative approaches with virtual consultation as well. And then also providing ongoing support and education to not only just those facilities, but to all providers based upon the themes and outcomes that were identified either through the DPH audits or through the on-site assessments. What were the specific themes and needs in order to provide additional support, resources, and education to the providers across the state in Massachusetts? So with that, we developed the scope and we developed that project plan with Mass Senior Care and Hebrew Senior Life. And then what Pathway had to do is we implemented really a project management, a leadership team, who our role was to really provide that oversight of the project and the consultants. There was significant amount of reports that came in. Just imagine 123 reports and then weekly reports coming in, as well as looking at trends and identifying of what those specific needs are and coordinating and ongoing communication, which you're going to hear a little bit more about how we did that through a very collaborative approach from us as external consultants, as well as Command Central, in order to meet the needs and the program initiative needs. And then I have to think about all of the logistics and scheduling that went around it. And thank you to Helen and to Pathways project management team for the quick scheduling of the on-site assessments, as well as these weekly supportive visits that went on as well. And then you'll hear a little bit more about some additional education that was provided by Pathway in order to provide additional boots on the ground support through the SWAT teams and through that process as well. So again, the team was consistent, it came together and provided not only the three-phased approach, but also provided the project management, the leadership, and the on-site to really continue and foster that communication collaboration that was going on in the backside and the back end. So we were able to provide the targeted support needed to the providers based upon where they were currently at and what their needs were in order to mitigate and reduce potential community spread and mitigate negative response in COVID-19 in their organizations. So Sue, as I talk about this overall, project and the way Pathway responded to it, could you tell us a little bit more about the phased approach and the needs and how we responded to and quickly ramped up to the needs of this project?
Absolutely, Lisa and Helen, thank you so much. So basically, dependent on the needs that were identified, we at Pathway worked simultaneously with Helen as well as the team to be able to then finalize the specific facilities for those on-site assessment needs. So the Pathway Health Project Management Leadership Team was then able to complete rapid response deployment of 9 consultants, their nurse consultants, to complete those initial on-site assessments in 122 facilities that were identified by the Massachusetts Senior Care Association and Hebrew Life Senior Command Center. The goal of these assessments was to determine if the facilities were in current adherence to the Massachusetts Nursing Facility Infection Control Competency Checklist that Helen had briefly showed you earlier, as well as to identify any infection prevention and control opportunities that could have led to non-adherence to the Massachusetts Nursing Facility Infection Control Competency Checklist in order to then be able to provide the support and technical assistance that the facility needed. The consultation and support was conducted in multiple phases. The phases that occurred simultaneously included the on-site assessment and then determination of any additional technical support and assistance to be able to provide, as well as training of the SWAT team for those boots on the ground additional assistance that the facilities needed, and then the support as well as education. Very quickly then, prior to the launch of the project, Mass Senior Care developed that SWAT team we were talking about, and Helen had mentioned earlier, which consisted of registered nurses who were then going to be able to provide additional targeted support and consultation to identified facilities who were presenting even greater needs after that initial on-site assessment. And in preparation for the project, then, I was able to conduct training with the SWAT team nurses and was able to talk about COVID-19 and long-term care, and then address CDC and CMS guidance for COVID-19. as well as the Massachusetts Infection Control Competency Checklist specifics, and then went through the PPE, personal protective equipment, as well as the general infection prevention and control overview, looking at best practices and CMS guidance as well.
So Sue, could you spend a few moments to talk a little bit about that on-site assessment, kind of that process and the tools that we used in order for having that good collaborative approach?
Yes, the on-site assessment then was provided, as you can see on the slide here, detailed infection control areas for all 122 buildings immediately. So within the 2 weeks of the initiation of the contract, our team utilized this tool that was designed by Pathway, Lisa and myself, that aligned with the Massachusetts Infection Control Core competencies of the checklist, as well as CMS and CDC guidance. The tool that the 9 consultants used was formatted basically, as you can see here, as an action plan in which then the consultants were able to assess the facility's current status with compliance. They were also able to determine if the facility had any potential or actual performance gaps, and that was provided through observation and interviews, and then to be able to provide recommendations for quality improvement in accordance with the current guidance. Following then the prompt completion of the action plan, the consultants would send in the reports at the end of the day to Lisa and myself for review and determination for next steps. The detailed action plan was basically designed to align with the nursing facility quality assurance and performance improvement process. Each report was reviewed and finalized by the Pathway Project Management Leadership Team, and then it was distributed based on a defined process. The assessment findings and trends were reviewed with Mass Senior Care and Hebrew Senior Life Command Central team members during the daily huddle meetings. Everything was organized and implemented very promptly and comprehensively with ongoing communication.
So Sue, once they completed that assessment and, we had that defined process and the communication was going on, can you walk through how it was determined what the level of support or technical assistant was needed?
Yes, so following the visits then, once the consultants submitted their reports to us, we looked at what was the next step. We would review these in detail, those action plans, and then Lisa and I would finalize the reports, and we would communicate with Helen and Command Central. And then Pathway Health and Command Central representatives determined what would be then the next level of assistance for these 122 nursing facilities following the below process. We would first review the initial assessment findings and trends, and then we would align those with the Massachusetts Infection Control Competency Checklist and the DPH audit adherence findings. We would then complete the determination criteria on what additional assistance would be needed in collaboration with Mass Senior Care and Hebrew Senior Life. And determination of the level of assistance included either no additional support, virtual visits every other week, or if they were not in adherence, in-person visits with the SWAT team and weekly virtual visits. So some examples of the key indicators that would show need for additional support and visitation included improvement in adherence. If they had no improvement in adherence, then we would take a look at what additional support we would need to provide. Did they have stable leadership of the administrator or ED or the director of nursing or infection preventionist? We also looked at the adherence to one or more of those core competencies. We would also take a look at, were they implementing recommendations in the action plan? Another area that would be looked at is COVID transmission within the facility. And then another area was, are they in staffing crises and they need additional support? So those were some of the areas that we looked at in determination for whether or not they would need an in-person or virtual follow-up visit.
And again, a reminder that, once the on-site assessment was conducted, this happened very quickly. The information came from the on-site consultant, that evening, and within 48 hours, the determination of what those next steps the level of assistance was completed. The report, the action plan with recommendations was completed and was then given back to the provider and working with facility leadership on determination of really what those types of assistance that the 122, 123 facilities receive. So Sue, can you talk a little bit more about those level of assistance that were provided to the organizations after the on-site assessment was completed?
Absolutely. So the targeted 2 hours per week on site would be in-person assistance on the SWAT team, which would include those observation audits, looking at meeting with that facility leadership team and having some good communications. Also meeting with the infection preventionists to talk about where they were in the process on adherence and any actions they put into place since the visit. Recommendations, did they follow through on those? Were they able to take the time to put any of those action plan areas in place? Additional education, possibly PPE, hand hygiene, resident placement. Also, the SWAT team partnered with a Pathway infection preventionist to work together during this on-site SWAT visit as well. Then they completed the weekly report. Lisa and myself reviewed that. We determined the criteria on whether or not they needed an additional visit, and of course, very good communication and collaboration with Command Central. That happened on a very regular basis, and then were scheduled for the next week if they needed on-site or biweekly or weekly virtual consultation. Next was the biweekly virtual consultation. These observation audits happened virtually, where they would carry either, they would use their phone, or they would be able to use a tablet or a laptop, and PHI and HIPAA protected secure link was used. They were able to meet with the facility leadership and the infection preventionist. Again, they go through those recommendations that were previously provided to take a look at where they were, how things happened, were they able to implement any of the action plan interventions, any additional education provided. Many times too, the consultant would provide additional resources for them to utilize for education and system implementation. And then also completion of a weekly report, which was again reviewed by Lisa and myself, determination on any follow-up visits and criteria. And then we would communicate and collaborate with Command Central, and then scheduling as well. And then lastly was the weekly virtual consultation. And then again, this too were observation audits, PHI and HIPAA protected, virtually secure link. And again, leadership and infection preventionist meetings were held to take a look at the recommendations to identify if any of those areas were implemented, additional education, resources, and then they completed a weekly report, which was reviewed, as is the other reports were reviewed, and to determine where are they in adherence. Where are they with the core competencies? Did they improve? Were there new areas that are opportunities for improvement? And then determination on criteria for further visits. And then we would communicate and collaborate with Command Central and schedule for the following week. And then on-site and virtual support assistance as well. Pathway incorporated additional Pathway infection preventionist, as well as the Massachusetts Senior Care and Hebrew Senior Life Command Center, and the SWAT team members. And we took a look at the initial findings and identified where those opportunities were. We also reviewed the EOHHS audit findings to identify non-adherence. We conducted process surveillance observation audits of staff practice. We also talked about strategies because proper cohorting and resident placement concerns was an area that was significant when we were working with their team. PPE was another area, and we're going to talk about that a little bit more as well. But we talked about PPE use as well as optimization strategies consistent with CDC. We also looked at cleaning and disinfection, consistent assignment and best practices. So as you can see, there were so many areas here where we could provide that just-in-time training, resources available to their team, and then we conducted some of the train-the-trainer exercises and participated in their quality improvement discussions as well. And then at the end, we did provide priorities and goals for the facilities for the next scheduled visit.
Thank you, Sue. So as you can see here, this is kind of a visual depiction of what happened within those 7 weeks. So again, that initial on-site assessment, the different types of consulting, whether it was virtual, whether it was biweekly virtual, or on-site assistance where there were additional boots on the ground, you know, all that was occurring at the same time. And obviously the goal was for improvement in compliance or adherence to the core competencies and the Massachusetts Infection Control Competency Checklist. But again, it was providing that support to those providers. So we worked with those facilities, and throughout the seven weeks, in addition to those on-site initial assessments, we did do an additional 362 encounters, meaning weekly visits or biweekly visits that occurred, working together to again improve outcomes and assist providers to become in adherence with the core competencies and the infection prevention, the infection control competency checklist. So one thing that is important to note, that although the initial assessments were completed quickly within a short time frame, all consultants who conducted those on-site assessments and the team members that were involved, none of them contracted COVID-19 throughout that process. So again, the audit, the process, and again, adherence was very, very important, and a lot occurred within the 7-week time frame, but we're very happy and pleased to say that were significant successful outcomes. But part of this process too, as we talked about before, that there was a phased approach that we, when working with Command Central, that not only providing the on-site assessments and the additional technical support and resources, but there also was looking at, were there overall trends? And Sue, can you talk a little bit about the discussion that we had with Helen and Command Central on identifying some overall trends for setting up that education, that overall education and those needs?
Absolutely. Education and training, we know, are key components to successful outcomes of any project, and specifically for this project was very important. We, as a team between Pathway Health, Massachusetts Senior Care, and Hebrew Life, took a look at some of the areas where there were trends, patterns, as well as a need for additional education. And as you can see on the slide, PPE was one of the areas. One of the unique areas in Massachusetts is the PPE coach. And so we had one on the role of the PPE coach, which was just an excellent opportunity for someone in the facility on all shifts to be able to monitor and work with the staff. So we specifically talked about the role and opportunities for them to do training and support within their facility. And so as you can see here, there were areas of non-compliance that we also addressed, and we looked at cleaning and disinfecting and how to hold staff accountable, and then sustaining successful outcomes, because many of these facilities showed vast improvement from when they started to the end. So how do you sustain those excellent outcomes? So again, that education was developed in the form of webinars that, based on the information and the team discussion that was able to be provided for these facilities to be able to have access to.
You know, and as Helen talked about earlier in our starting of this presentation, was really that collaborative approach and working together to make sure that not only initiative moved forward, but that we were able to respond quickly to any challenges or questions that were brought up, not only from the on-site assessments as well as the ongoing support that we provided, but also where there's some additional challenges or maybe variances in approach or guidance that were out there. And as you can see here on the slide, part of these were some of the subjects of the routine. As Helen talked about, these huddle meetings, Pathway was involved in daily huddle meetings, and in the beginning was 7 days a week, and we were able to reduce the amount of huddle meetings to about 3 times per week towards the end of our 7-week stay here. But we were able to talk about some of the challenges that were identified, where there's some national best practices that we wanted to incorporate, whether it was in the education or through the approach with the technical assistance, and then also looking at were there variances, as Sue discussed and also Helen discussed earlier, about the variance in guidance between the state level and the federal level, and how facilities, the providers were supposed to respond. As we all know, in the beginning of the pandemic, a lot of changes happened very quickly on guidance as we learned more about this virus and the pandemic and the response processes that we needed to put in place. So again, this overall enhanced coordination and communication, truly in those daily huddle meetings, really helped us be able to quickly respond back to the providers and get them the resources and the education or support that they needed in order to help them with adherence. So again, not only logistics with coordinating and scheduling, and as well as maybe there were PPE needs in a specific location, we were able to address that. So again, looking at what we can do to reduce the spread within those locations and to be a support for those providers together with Command Central to be able a coordinated effort to really look at the overall outcomes and how we can improve outcomes. And Helen, part of that process, weren't there some additional initiatives that also you and Command Central worked on in addition to what we worked on with you with Pathway Health, correct?
Yes, there was. So we were lucky enough that Mass Senior Care and Hebrew Senior Life met at least weekly with the Executive Office of Health and Human Services and the Department of Public Health to discuss questions that were coming up during the on-site and virtual visits and during webinars. I don't think I can overstate how very important this was and what a unique opportunity it was for us. Our leaders had open access to people from the state command center, so when questions came up or support was needed, it was simply a reach out to the state command center, and that support was provided. The Executive Office of Health and Human Services was overseeing the auditors. We were overseeing the infection control consultants, and we were moving so fast, and the guidance just seemed to be evolving weekly. We had frequent communication between our command center leads and key leads from the state agencies, and that was crucial in overseeing the initiative. We were able, during that time, to work with the Executive Office of Health and Human Services and DPH to develop FAQs that we could send out to the providers on a weekly basis. And when new things came up and challenges came up, we could get the answers to them quickly. We also had access to PPE, and I spoke about this a little bit earlier. The PPE work group helped facilities find PPE. You may recall hearing about a PPE shortage early in the mass experience, and it was a severe shortage. Nursing facilities faced very substantial challenges with accessing PPE, despite the fact that there were available funds made available to them to do so. The command center worked to locate and vet suppliers. We made group purchasing orders. We facilitated getting critical supplies to facilities with critical shortages. I spoke before about the development of a burn rate calculator to help these facilities determine how quickly they were using PPE, and it was based on the number of cases that we were seeing in their facilities. The staffing work group worked with individual facilities to help them utilize the long-term care facility staffing team portal. We did webinars in conjunction with the state on how to access this, and again, I also talked about how we developed a monster.com platform or website that could help recruit staffing for facilities that were in need. And finally, there was the testing of all the residents and staff, and that initially was being done by the Massachusetts Army National Guard. Facilities could call and could schedule a time, and the National Guard would come in and test all residents, and then they opened that up to start testing all staff. And we also enlisted the help of some private labs, including the Broad Institute, to get testing to our facilities quickly so that residents and staff could be tested.
Thank you, Helen. And we know, prior to us showing that you guys all the final outcomes and this grateful successes that occurred throughout this initiative, I do want to spend a few moments to talk about, some of the challenges. And Helen and Sue, can you discuss a few of these highlighted challenges and our lessons learned that we learned throughout this project together?
Sure. So as far as I'll take the conflicting guidance piece because my role is the Director of Regulatory Affairs at Mass Senior Care. So this was a challenge that was near and dear to my heart. So we were receiving conflicting guidance, and it wasn't by anyone's fault. It was just that things were changing so quickly, during the beginning of the pandemic and the outbreaks that were happening in Massachusetts that facilities were getting conflicting guidance from what to follow for PPE. And the guidance was coming from the Executive Office of Health and Human Services, Department of Public Health, CMS, CDC. So that was a challenge to keep all of that straight and to keep the facilities following the guidance that they were being advised to follow by the state.
And this is Sue, one of the challenges that the consultants did have with the facilities is there was so many questions on PPE use. What is considered PPE? When are we supposed to use it? And ambiguities. They were looking at when to use full PPE if community spread, for cleaning, what PPE and where in the hallways. Infection control in close congregate spaces is very challenging under the best of circumstances with a lot of people living in close quarters. And so there was quite a bit of ambiguity when it came to what PPE to use, which was necessary, which units in the early months of the initiative. They also were looking at full PPE, gowns, glove, mask, face shield, if a facility had no recent cases, but there was community spread in the local community. And how was community spread defined back then? Because remember, things have changed from then until now. Also with residents with dementia who wandered and had difficulty wearing masks and staying in their room and maintaining that social distancing. So that was a challenge. And really, the inability to adhere to guidance when PPE is in short supply. So those were some of the big areas. And once again, residents with dementia who were moving around facilities and really had that difficulty understanding why they were not able to do that as much as they were before, and then wearing masks. So this was hard. PPE was probably the #1 area that we really did identify challenges during this process.
And we also had some challenges with the constantly changing resident categories for cohorting and PPE use. So, and again, all of this began to evolve as we got more and more information on COVID-19. So initially we were looking at symptomatic versus asymptomatic when we were cohorting. Then we went to symptomatic versus asymptomatic versus exposed, or PUI. And then we looked at testing. We were testing the COVID negative, testing the COVID positive, asymptomatic positive, PUIs. And then we added on recovering. And I will tell you that this was difficult because not too many states have started to deal with patients that were recovering from COVID-19. But Massachusetts, since we had an early outbreak, now had to start thinking about these recovered patients. So these patients that had contracted COVID in March and April, now we're in May and June. And what do we do with them? And where do we put them? Do we put them with COVID negatives? Do we put them with COVID positives? Do we put them with asymptomatic positives? Do we put them with PUIs? So it really became a challenge as far as cohorting. And the cohorting was happening every day because lab results were coming back every day and residents were showing symptoms. And so facilities had to really develop really keen skills in looking at their results every day, looking at their line listings, and making sure that they were cohorting patients appropriately. There was also challenges with temporary staff. As we said, facilities had to use temporary staff to cover these staff absences that were largely due to the staff being out sick themselves. So the National Guard was provided by the state, and they would provide a crisis response team for 5 days of coverage. And then there was a new program to provide ancillary support that was developed and was called the Resident Care Assistance Program. And that was to help solve the critical shortages in CNAs. But what came with the RCA position was people were concerned because these were people that were being brought into the facilities. Because of 1135 waivers, they were allowed to use resident care assistants as long as they could, perform, and they had competency assessments so that they could meet the federal and state regulations. But the problem was, once we get these resident care assistants into the building, what do we do with them? They will continue to be resident care assistants. So in Massachusetts, there was a lot of work done by our workforce group that worked with our Department of Public Health to allow for some online CNA training in specific facilities, which certainly has helped the workflow and has also helped the flow of new staff into the buildings. So I think, these challenges really illustrate how critical it is to have a coordinated response. The PPE issue is one we picked up with the on-site consultants that required both training and surveillance from infection control consultants, and how also to help from the PPE work group to access supplies and frequent communication with the Executive Office of Health and Human Services and DPH to help clarify that guidance.
So Helen, can you talk a little bit about some of those initiative lessons learned?
Absolutely. So what we did learn was that you need to over communicate in a crisis. You just cannot communicate enough. Our command center met frequently. Our overall command center met frequently. We were meeting 3 times a week in the evenings. And, at some point we were able to decrease that frequency. The infection control team, we were meeting on a daily basis. And as things progressed, we were able to make those meetings less frequent. But they certainly continued until we were sure that the initiative had been successful and that the facilities had gotten the support that they needed. Our SWAT team meetings, we would meet with our SWAT team consultants once a week to review the site visits that they had made, to work through any sort of concerns or issues that they would have. And it also gave us the opportunity to then provide feedback to Pathway Health about additional visits and additional information that was needed. Meeting with Executive Office of Health and Human Services and DPH was crucial. I mean, we, again, as I spoke earlier, we had the ability to really reach out at any point in time for guidance and for assistance when needed. And I will say something that was very different in this process and during this initiative was sort of the spirit of inquiry versus the punitive approach. So what we saw with these infection control audits, although they were state survey, some were CERT survey agency staff, was that there was not a punitive approach. It was a different approach. It was something different than facilities had seen, but the facilities appreciate it. It wasn't looked at, when facilities got something wrong, we were able to help them the next time around, but it wasn't punitive. And when auditors got it wrong, the facilities had the ability to appeal. And if they had evidence as to why they felt that that particular competency was scored inaccurately, it was reviewed, and facilities had that opportunity to have it reversed.
That's great. Thank you, Helen. And then Sue, could you tell us a little bit more about some of the lessons learned at the facility level?
Yes. So at the facility level, we talked about that comprehensive observation that is so essential. We took a look at some of the needs for education and training for some of the ancillary staff that were not able to speak English or maybe even had problems with reading. So we were working with that really understanding of that education need. We also took a look at communication between the whole team on demonstration of correct technique so that we were able then to prioritize what areas needed to have improvement and then work on those areas as well. We also talked about the frequent comprehensive communication and how necessary it is. And I know Helen mentioned that as well, that you can't over communicate. So we would communicate with them as well on the facility level on follow-up. And then certainly the alignment, clarity, and transparency with guidance And if you don't know, you don't know. But what we really certainly wanted to make sure was that they had resources to be able to then understand exactly what processes they needed to put into place so that they had good systems for adherence and also compliance to best practice approach to infection prevention and control.
And thank you, Helen and Sue. You know, looking at this and realizing this initiative and in the short time frame that it was, knowing that collaboration, communication, and a non-punitive approach was really part of the hallmarks of success of this program. And although we gave you a brief overview of this initiative and kind of the steps that we went through and through the process, as well as the high-level challenges that came about, we know that it was a short time frame. You know, there was a specific initiative and a need, and there were a lot of moving parts and processes that led really truly to that overall successful outcomes for the facilities. So Helen, as we wrap up today, can you just walk us through briefly some of the moments of those, really those highlights of some of the overall successes of this initiative, because it really speaks as you see the visuals here.
Absolutely. So what you see on your screen now is actually the results of the audit. So the 123 special focus facilities, although I don't want to call them special focus facilities because that has another meaning, but those facilities that we provide the additional technical assistance to, you can see their progression from their first audit, the percentage that passed and the percentage that failed, to the fourth audit. We saw a big bump up on audit number 3 with those that passed. And really a decrease in those that failed. In audit number 4, we saw a little bit of a decrease in the passing grade, but you know, we started to think that maybe facilities were feeling good about the way they were doing things and may have taken their eye off the ball. But overall, going from a 36.6% pass rate to an 87.4% pass rate for those 123 facilities was really remarkable. And then you can also see the other facilities. They also continued to increase their passing rate. And I will say that the webinars that were presented, we presented them weekly for 7 weeks. Those were open to all facilities. They were not just open to the focus facilities. And we had close to 300 to 400 people participating on those calls every week. Next slide, Lisa. Okay, and here you also see the resident weekly infection rate that was tracked. And you can see that there was a sharp decline in the weekly resident infections following the first audit. The other facilities had a small uptick in the last week, but those that we had provided additional technical support really saw a significant decrease. And there was also a similar decline in the staff weekly infection rate, but there was also a slight uptick for both groups in the last week of the initiative, but it was a significant decrease. And resident weekly COVID-19 mortality rate, as you can see, this was a significant decrease, and it actually declined to less than 0.2% by the end of the project. So results from the initiative were published in the Journal of American Geriatric Society in July. There were 2 data sources that we used for evaluation. We used the checklist scores from all the nursing homes, and we used the weekly nursing home report that facilities had to submit to the Massachusetts Center for Health Information and Analysis. The checklist scores, adherence to the 6 core competencies, average weekly rates of new infections, hospitalizations, and deaths were analyzed. Results were reported for the 2 groups. The special focus group of 123 that received technical assistance from an infection control consultant, and those that did not. We found that both resident and staff infection rates started higher in the special focus facilities and then rapidly declined to the same low level in both groups. And adherence to the infection control processes, especially proper wearing of PPE and cohorting, was significantly associated with declines in weekly infections and mortality rates.
So in summary, there were conclusions that were drawn based upon the data and research, and you saw visually the drastic changes and the improvements that came and the unprecedented approach to this, to really improving infection prevention and control in targeted locations, as well as all provider locations across the state. And part of the conclusions that have been drawn is that by providing monetary incentives and guidance, as well as the resources to nursing facilities, states may be able to improve infection control practices. Hopefully, this will reduce the rates of COVID-19 infections amongst nursing home residents and staff. And while it's still unknown whether improvements are due to the statewide intervention or can be sustained without those payment incentives, but mechanisms to further develop and sustain infection control practices beyond COVID-19 pandemic are needed. So throughout this short time frame of this project, we did see significant improvement. It was identified as well as quantified. And you can see, of course, you'll be able to access that paper that was published on this. So the coordinated effort between the state regulatory and financial entities, the Provider Association, Mass Senior Care Association, as well as Hebrew Senior Life, academic settings, and facility leadership, was not common and was very innovative in the approach. And because of that, they were able to identify the communication needs, the response needs, the rapid response needs, as well as the resource needs and the consultation needs and additional education needs for providers out there to sustain and improve adherence to the infection control competency checklist. So in summary, we really recommend this innovative approach and initiative be utilized in other states, working together from a regulatory perspective to financial perspective to key stakeholders and leading to additional support and assistance to providers will really improve adherence to outcomes and ultimately provide quality outcomes for our residents. So again, today we want to thank you for taking time out of your very busy schedule to hear a little bit more about this innovative program, the Massachusetts Initiative to Improve Infection Control in Nursing Homes. Thank you, Helen and Sue, for joining me today. And again, I want to thank everybody for joining us. And we open up for questions. And if there aren't additional questions, we are accessible anytime, and you'll be able to get our contact information to learn further details about this innovative program.
Lisa, I do not have any questions at the moment. We can wait just a few more minutes to see if anyone has any questions. This webinar will also be downloaded and posted to the ASA members section of the website by Friday. Still no questions, Lisa.
That is okay, Tara. And of course, we can, if people, again, you can reach out to Helen or to Sue or myself to learn further information. And again, we highly encourage you to download that research paper. It really truly outlines all the things that we had today. And again, we're open for you to reach out to us to talk a little bit more about this and how we can help you present this to the state itself in this collaborative approach.
And ASA thanks you so much, Lisa, Helen, and Sue. We would very much appreciate it. Thank you, ladies. No further questions.
Thank you.
Thank you.